Hello everyone, today I'm going to talk about acute appendicitis. So we'll go through a case and it will be related to surgery. Here we have a 21-year-old male university student presented to the emergency department to the hospital in March. 14-hour history of abdominal pain that initially began in the periumbilical region and later migrated to the right lower quadrant. He reported he had nausea, one episode of vomiting, anorexia, and low-grade fever. If we talk about anamnesis, morbid history of present illness, he's having pain for almost 14 hours, sharp continuous pain, symptoms nausea, vomiting once, low-grade fever, anorexia. There is no diarrhea, urinary symptoms of previous similar episodes. Vitals are heart rate, which is 102, temperature 38.2 degrees Celsius, BP is 1 to 24/78. If we talk about anamnesis with a past medical history, he's been clean, childhood, healthy, vaccinated, lifestyle, no non-smoker, no alcohols or drugs, diet balance, exercise, regular gym or sports, psychosocial, good academic standing, no mental health issues. General physical examination, the patient was seen alert and uncomfortable. Skin was warm and no rashes. Mild tachycardia, respiratory normal, temperature 38.2 degrees Celsius, mild fever, might be due to infection or inflammation. It suggests infection or inflammation. If we talk about hydration, there is mild dehydration. Motility lies still, prefers to lie still, pain on movement. When we're doing abdominal examination inspection, there were no scars, masses, or distension. Palpation, there were right lower quadrant tenderness, guarding McBurney's point rebound. Percussion, localized right lower quadrant tenderness. While doing auscultation, normal bowel sounds were heard. If special signs such as row signs positive, SWAS positive, obturator positive, and Bloomberg positive for this patient. If we're doing laboratory investigations, CBC was high 14,500, in which neutrophils were 85% high. Hemoglobin was 13.8 normal, hematocrit normal, platelets were normal, but there was a slightly increase in CRP 35 milligrams per liter. Pancreatic enzymes, amylase were normal, liver functions, everything was normal. Other tests, urine analysis, electrolytes, everything was normal. Pregnancy test not applicable because it's male, but in females we have to do pregnancy test. It becomes necessary for appendectomy in pregnant patient because it puts risk for both the mother and the fetus. If it is delayed, then it can lead to perforation, sepsis in the mother, and fetal death can even lead to fetal death. Fetal death chances might increase from 3% to 30% to 40%. Peritonitis, many major risks for delaying appendectomy in pregnant patients. If we talk about next radiological evaluation, we can do ultrasound, but more preferable is CT scan, which is gold standard method. Here we use contrast enhanced CT scan. What we see here is appendiceal wall thickening more than 2 millimeters, periappendiceal fat standing, and you can see enlarged appendiceal diameter, which is 6 millimeter with occluded lumen. Therefore, there is no perforation or abscess. Conclusion is that acute uncomplicated appendicitis. Next, if you move on to Alvarado scoring system, we have to score it from 10 points. Migration of pain to right lower quadrant is 1 point. Anorexia 1 point. Nausea, vomiting 1 point. Right lower quadrant tenderness 2 points. Bone tenderness 1 point. Fever more than 37.3 degrees Celsius is 1. Leukocytosis 2 points. Neutrophilia is 1 point. Total score is 9 out of 10. You might ask, what is the 1 point missing over here, which is actually shifting of right lower quadrant tenderness to the left lower quadrant is another 1 point which is missing here. So what does it signify? 7 to 10 points are highly likelihood of appendicitis, 70 to 100% risk. 5 to 6 points moderate likelihood of appendicitis. For 0 to 4 is 20% risk of appendicitis. We move on to next, emergency room management. First, we have to give the patient fluid resuscitation. We give them saline or ringer lactate, normal saline or ringer lactate. IV infusion should be done to correct the dehydration, maintain intravascular volume, and if there is any disturbances in electrolyte imbalance, we have to maintain them. Then we'll move on to antibiotic therapy, in which we give broad spectrum IV antibiotics to prevent or control infections. We have piperacillin, tazobactam, 4.5 grams of IV every 8 hours, or combination of ceftriaxone 2 grams IV once daily with metronidazole 500 milligrams IV every 8 hours, based on the local guidelines and severity. Pain management depends on the severity. If it's mild to moderate, we'll go through acetaminophen or NSAIDs. If it's severe, then we have to shift to morphine, which is 2 to 5 milligrams of IV for severe pain. Now moving on to the surgical management. We have both open and laparoscopic management. If you talk about more about laparoscopic management, preoperative preparations. Patient is placed under anesthesia, supine position. We have to prepare the patient. Sterile preparation, draping abdomen to maintain sterile feel. Mark the right lower quadrant. For incisions. Then what we have to do is we have to make a small vertical incision 1 to 2 centimeter at the umbilicus. Then we have to insert the trocar, which is 10 millimeter, into the abdominal cavity under direct vision. Trocar is used for laparoscopic insufflation. What it does here is it insufflates the abdomen with carbon dioxide to create pneumoperitoneum, inflated abdominal cavity, which provides us a space for visualization and manipulation. Then we have to insert both 5 millimeters, one port in the right lower quadrant and another in the left lower quadrant. Locate the appendix in the right lower quadrant. Then mesoappendix is carefully dissected. Mesoappendix contains blood vessels that need to be ligated to clip to control the blood supply of the appendix. Okay, the base of the appendix is where the appendix is attached to the cecum, the beginning of the large intestine. The appendix is carefully separated from the cecum using electrocautery scissors or surgical stapler. Ligation of the blood vessels. The blood vessels supplying the appendix are sealed by either suturing, clipping, or using the vessel sealing devices to prevent bleeding. In the mesoappendix, it has blood supply. It has nerve supply to the appendix, and it has lymph supply to the appendiceal organ, which has to be. So first we have to focus on clipping the appendicular artery and vessel sealing device to prevent bleeding. Appendiceal removal. After the appendix is detached from the cecum, we have to see if there is any bleeding, and the appendix is removed through one of the incisions, usually the umbilical incisions. And remember, umbilical incisions are not done in women's due to herniation problem. Inspection of abdomen. Check the abdomen for any fluid leaks, free fluid, or remaining infection. Deflate the abdomen cavity, slowly releasing the carbon dioxide gas to restore normal abdominal pressure. Closing the incision. Umbilical port close with absorbable sutures or skin glue. Other ports close with absorbable suture with skin staples. Ensure if there is no leakage or incision from the incision sites, and the abdominal cavity is free of any contamination. Post-operative care. So look for vitals or wound monitoring, such as blood pressure, heart rate, oxygen saturation. Mobilization starts in 6 to 8 hours. Diet. The patient should be given liquid until 6 hours after the operation. Soft diet in 24 hours. Analgesia, paracetamol, and NSAIDs will be given, but we have to continue antibiotics for 1 to 2 days after the operation. If there is any concern about infection, especially if there is a sign of perforation or abscess, discharge will be done in 1 to 2 days depending on the recovery. Follow-up of the patient will be called again for after 1 week for wound and histopathology. Antibiotic protocols, EAES guidelines: uncomplicated cefuroxime or cefotaxime plus metronidazole for 24 hours. Complicated, piperacillin and tazobactam or meropenem for 3 to 7 days will be given. Source is EAES and SISE guidelines. That's it for now. Thank you so much for listening. If you like the video, make sure to leave a comment.